To continue off from yesterday, we talked about, different classifications of organisms in very broad terms, right? We didn't really go into like super granular detail about everything that we talked about. We're going to be going over those different classification systems like nomenclature, things like that. We're going to go into more detail in future lectures for this class. But that was just kind of like a brief overview of some of the different microorganisms that we're going to be discussing throughout the rest of the semester. So let's talk about infections. So that's kind of like the purpose of studying microbiology, right? Because microbiology is cool when you're, studying different microorganisms and, kind of the things that they do. But in terms of medical application, we're mostly going to be concerned about organisms that cause disease, right? Organisms that cause disease and organisms that can help fight off diseases as well. Because when we start getting into antibiotics, we're going to discover that a lot of our antibiotics are going to be derived from other microbes, right? So think about penicillins, right? Beta-lactam drugs, they originate from Penicillium, which is a genus of fungi. Other organisms, a good example would be Streptomyces, which is what we derive streptomycin from. And, lots of our antimicrobials are going to be derived from other living organisms. So, there's ones that are going to be beneficial and there's ones that are going to be pathogenic, and we can use the ones that are beneficial to fight off the ones that are pathogenic. Now, when we talk about pathogenicity, we talk about organisms in terms of virulence, right? We kind of discussed very briefly last night virulence factors. So some examples would be capsules, as well as slime molds, or sorry, not slime molds, but slime layers, aka biofilms. Biofilms are particularly pertinent to indwelling catheters. So we're talking central lines or Foley catheters. Oftentimes, those are going to lay the groundwork for biofilm accumulation. So you have like bacteria effectively colonizing those surfaces, resulting in bacterial infections. So that's going to be what we refer to as virulence factors. And there's a lot of different virulence factors. Some are going to be endotoxins versus exotoxins. When we refer to endotoxins, those are going to be components that are innate to the bacteria that result in a disease process. So when we talk about gram-negative organisms, for instance, there's going to be an element that make up the outer layer. It's called a lipopolysaccharide, LPS for short. And those lipopolysaccharides are going to result in endotoxin formation. And so those are going to be things like the O antigen or lipid A, which is like the anchor. Those are going to mount an immunologically mediated response from the host, assuming that the person has an infection with a gram-negative. So those are considered endotoxins. So we're going to talk about those in greater detail once we get into gram-negative versus gram-positives. Exotoxins are going to be components that are actually secreted by a bacteria that results in disease. So a good example of exotoxin could be something like exfoliatin, which is released by certain strands of Staphylococcus aureus. And if you have an organism that can produce exfoliatin, it's going to cause sloughing off of your skin. So it'll slough off the superficial layer of your epidermis. And so that can result in things that look kind of very similar to a like first degree burn. You see that a lot in like neonates, for instance. They'll get like exfoliatin, like kind of like a scalding skin syndrome, often around their buttocks. There's a lot of different exotoxins. We're not going to go into detail on every single one of them, but it's good to have kind of like a general idea of endotoxin versus exotoxins as they relate to virulence factors. So moving on. So we already kind of covered the bases on all the classifications or the classes of microbes that we're going to be discussing: bacteria, viruses, fungi, and parasites. When we talk about parasites, we're mostly referring to helminths, right? So remember those, like all those different types of worms, whether it's like Tinea solium, Tinea saginatum, Ascarius lumbricoides, all those types of parasitic worms. Now, let's talk about the way in which your body is able to fend off these different types of foreign invaders, right? So you have a couple different branches of your immune system. The two major branches are going to be what you're born with versus what you acquire throughout your life, post-exposure, right? So when you're born with something, it's going to be referred to as innate, right? So you're born with your innate immune system. Your innate immune system is going to be made up of multiple different factors. First lines of defense are going to be actual physical barriers. Think about skin, okay? Other things that might be falling under innate immune system could also be chemicals that are produced that can actually break down and kill certain types of organisms. So one great example is going to be lysozyme. Lysozyme is released in your saliva as well as your tears, right? So your parotid glands as well as your lacrimal glands are going to be releasing lysozyme. And what lysozyme does is it breaks down peptidoglycan cell walls. Remember, peptidoglycan is going to be the cell wall component of bacteria. Gram-positives have a really thick peptidoglycan, but gram-negatives also have peptidoglycan, but it's a lot thinner. So lysozyme is going to actually come in to help to break those down. It has a very similar mechanism of action as beta-lactams. A little bit different, right? Because lysozyme actually breaks down the peptidoglycan directly, whereas beta-lactam drugs are going to inhibit the synthesis of peptidoglycan cell walls, but they're going to have a very similar effect at the end of the day. Other things that could be falling into that innate immune response would be like inflammatory processes, right? So when you have inflammation like rubor, tumor, which is like swelling, redness, heat, pain, that swelling is going to be a result of increased capillary permeability, right? So you have vascular permeability, which allows for white blood cells to enter into those interstitial spaces to be able to actually kill off any of those foreign invaders. So that's going to be the inflammatory process. Fever also plays into that. When we incubate a lot of these bacteria in our lab, we incubate them at 37 degrees Celsius, which is about 98 degrees Fahrenheit, aka body temperature. So a lot of bacteria really enjoy growing in body temperature. That's their like particular niche. Some are going to be a little bit more on the lines of like a colder temperatures. So a good example would be Mycobacterium leprae that causes leprosy. Usually likes like 25 degrees Celsius. That's why it affects your fingers, your nose, your ears when you get leprosy. They prefer cooler environments. But for the most part, a lot of bacteria like body temperature. So if your body if you're infected with a bacterial, agent, and then you start spiking a fever, that's your body's way of trying to make it too hot for the bacteria to reproduce. Sometimes it can actually kill the bacteria as well. So that's going to be part of your innate immune response. Adaptive immune system is going to be subdivided into two major categories. One is going to be called the humoral immune system. If you studied ancient medicine, you would probably be familiar with the four humors. If you study like, I don't know, Hippocrates, guys like that, like really old ancient medicine from like over 2000 years ago, they talk about the balance of the four humors. There's like green bile, black bile, and a couple other ones too. But they're talking about the fluids in your body. And so when you talk about the humoral immune system, you're talking about fluid immunity. And that's going to be moderated by B cell lymphocytes, which turn into plasma cells. And those plasma cells, which make up over 50% of your blood, those plasma cells are going to be secreting immunoglobulins, and immunoglobulins are going to be predominantly associated with that humoral immune system. Then the other major category in the adaptive immune system is going to be the cell-mediated immune system, and that's going to be predominantly moderated by your T cell lymphocytes. So humoral immune system. Let me get my marker here. Humoral immune system are going to be B cells. So that's going to be your humoral immune system. And then your cell-mediated immune system is going to be your T cells. And B cells and T cells are both lymphocytes, right? So we have 5 different categories of white blood cells. One of those categories are going to be your lymphocytes. And lymphocytes are subdivided into B cells and T cells. And there's going to be different types of T cells involved as well, but we'll get into more details on that a little bit later here. So here's an overview of those different immune responses. You have your innate immune system, which is what you're born with, right? So it's going to be first line of defense, physical barriers, skin, mucosal membranes, tears. And when we say tears, we're predominantly referring to lysozyme. Lysozyme is what breaks down those peptidoglycan cell walls in bacteria. Then second line of defense could be your phagocytic cells. So we're talking about macrophages or neutrophils. So we kind of write it like this. So neutrophils could be like N naught, and then macrophages would be M naught. So macrophages or monocytes are going to be just kind of like your run-of-the-mill phagocyte that's going to be able to gobble up foreign invaders. Then third line of defense is going to be moderated by your lymphocytes, right? So these are going to be L, I usually write them as L naught. So those are going to be your lymphocytes. So innate immune system, as we already mentioned here, you are born with it. It exists at birth. You don't have to have prior exposure to the pathogen or the antigen. The antigen is going to be something that generates antibodies. We're going to talk about that a little bit later, but you're born with this, right? You're born with skin, you're born with mucosal membranes, you're born with the ability to produce lysozyme, you're born with the ability to mount an inflammatory response. So you don't have to be previously exposed to anything. And it's not specific, non-specific. It does not discriminate against one type of antigen or another type of antigen. If it's a foreign invader, it's going to go ahead and kill it, right? Or just try to kill it and neutralize those foreign invaders. Does not require prior exposure, so it's not like the adaptive immune system. And then inflammatory response is going to be key in this, right? So think about your 4 cardinal signs of inflammation. So pain, redness, swelling, okay? Sometimes you might get loss of function as well. So we kind of already went over all this. Lysozyme is going to be a key component in terms of chemicals that are released in the primary first line of defense. Saliva is going to be directly associated with lysozyme. Acidity in your stomach is also going to be associated with, your first line of defense. There are certain organisms that cannot withstand acidic environments. Interestingly, one is going to be Giardia. Giardia, when it's in its trophozoite form or its mature form, if you consume Giardia in its trophozoite form, it will actually die in the low pH of your stomach. So when you get Giardia, it's usually because you ingested the eggs, right? The oocytes. Once you ingest those eggs, those are actually able to withstand the acidity of the stomach. It will bypass the stomach, get down into the small and then large intestines. And then once it gets into those higher pH regions in your GI, that's when it becomes a trophozoite, and that's when it actually causes disease. And then for your genitourinary tract, usually it's just mechanical release of urine. That's what flushes out organisms that could potentially cause UTIs, right? So a lot of our antibiotics that are used against UTIs, think about Bactrim, which is trimethoprim sulfamethoxazole. That drug is going to be bacteriostatic, so it doesn't kill the bacteria. What it does, it prevents the bacteria from being able to grow. And so what it allows your body to do, it allows your body to go ahead and either mechanically flush out the bacterial infection, or it allows your defense system to go ahead and phagocytose or kill off those infectious agents. Cool. So mucosal membranes. Mucosal membranes are going to be found in your GI tract, respiratory tract, genitourinary tract. The biggest thing that's going to be associated with your mucosal membranes are tears, right? So tears, you're going to find lysozymes in those tears. So if you're, little emo boy over here crying, it can be a good thing. So it can actually kill off a lot of the bacteria that might be in your, entering into your mucosal membranes in your eyes or even in your oral cavity. When you get into your respiratory tract, you're also going to have the mucociliary escalator. And here's an image of what that looks like. You have lots of cilia that come off, projecting off of those columnar type cells. And those cilia are going to be batting in one direction. They're going to be batting upwards, right? So even though like 30% of people have Streptococcus pyogenes in their mouth, a lot of people have strep pneumoniae in their oral mucosa. The reason why a lot of those organisms don't cause respiratory infection in people that have, those bacteria as part of their natural, mucosa or microbiota, it's because the mucociliary escalator keeps them out of the lower respiratory tract. So that's going to be a really huge aspect in protecting your respiratory epithelium. So here's just like an overview of a lot of these things. So lysozyme, that's going to be one of the key components. You also have peroxidases as well, lactoferrin. The interesting thing about iron is that bacteria absolutely love iron. As a matter of fact, there's a lot of fastidious type bacteria, like for instance, Neisseria organisms. So Neisseria gonorrhoeae, Neisseria meningitidis that cause gonorrhea and meningitis. Respectively. They're called fastidious, which means that they actually require a lot of energy or nutrients on an agar to be able to grow them on a culture. And so we usually grow them on chocolate agars, which is made up of hemolyzed blood. When it's a hemolyzed blood agar, it's going to have lots of iron in it. That iron-rich environment allows for bacteria to grow on that medium. And so lactoferrin is going to be like an iron chelator. So it binds to iron, so it prevents bacteria from being able to consume that iron as a nutrient source. And then second line of defense, we kind of talked about neutrophils as well as macrophages. Those are going to be your major phagocytic cells. Neutrophils, monocytes, and macrophages kind of fall under the same category. You also have dendritic cells. Now, dendritic cells are kind of interesting. They look like dendrites. They have these finger-like projections, and those finger-like projections are going to go out into the environment, and they're going to be scouring for different antigens in the environment. So a good example would be your mucosal associated lymphatic tissues, or MALTs. That's going to be called MALTs, M-A-L-T. And those are going to be found in your GI tract. And what those MALTs are, they're going to be kind of these patches of tissues that have lots of dendritic cells in them so that they can pick out antigens that are potentially pathogenic in the environment. And what they do is they gobble up those antigens, and then oftentimes they'll present those antigens to T cells. And once they present those to T cell lymphocytes, then those T cells can become activated. It's either a T helper cell that can activate macrophages to go off and kill whatever it is that's producing that antigen, or it can activate cytotoxic T cells, which can directly induce apoptosis in any infected cell. So we're going to talk about those in a little bit more detail later on. But those are going to be some of the major phagocytes that we're dealing with: neutrophils, macrophages, dendritic cells. And then phagocytosis, there's a video here that you can see what phagocytosis looks like. It's actually a pretty sweet video. I'm not going to be able to play it here today. I will try to play all these videos next week when we meet for the first time in person for lecture. So you can kind of see some of the things that we were talking about in more detail. But these are going to be different types of components that activate receptors on these types of cells. So you can have things like flagellin, which is going to be, activating flagellin receptors in a macrophage. Peptidic glycans can also activate macrophages. Lipopeptides can activate macrophages. And once those receptors get activated, that's what allows for the phagocyte to go in and actually gobble up those foreign invaders. So fever and inflammatory response, kind of going into a little bit more detail about those primary defense systems. Fever, as we mentioned, it's going to mostly affect those bacteria that enjoy body temperature, right? 38 degrees Celsius, 37 degrees Celsius, 98 degrees Fahrenheit. Inflammation, that's going to allow for greater vascular permeability. It's going to allow for white blood cells to go in, enter into interstitial spaces to go and attack those foreign invaders. So let's talk a little bit about all the different leukocytes. We already talked a little bit about neutrophils, and we talked a little bit about macrophages, which are derived from monocytes, and we talked a little bit about lymphocytes as well. But in terms of the major categories of leukocytes, right, you have your granulocytes, and then you have your agranulocytes. Granulocytes are going to be your leukocytes that have granules on the outside of the cell. And depending on what type of cell it is, those granules will release different types of compounds to attack foreign invaders. Neutrophils are going to be predominantly associated with bacteria. So think neutrophils, you're going to mostly think bacterial infections. I'm just going to abbreviate BACT. So neutrophils are going to be the very first leukocyte at the site of infection. They're going to cause a great deal of damage because what they do is they can not only phagocytose foreign invaders, they can also undergo oxidative burst, which is where they blow up and they release these reactive oxygen species that are able to kill and compromise the phospholipid bilayer of bacteria. They also release these things that they call nets, which are made up of DNA from the neutrophil. And the nets release these negatively charged histones that can bind onto bacteria and trap them so that they can become gobbled up by other phagocytes down the line. Eosinophils are going to be associated with parasitic infections. I'm just going to abbreviate para. Okay, so those parasitic infections, we're talking like worms. We're talking liver flukes, helminths, anything like that. If you see a spike in eosinophil count on a patient's labs, you're going to think that the patient probably has some sort of parasitic infection. Basophils are going to be associated with allergic reactions, and they're going to be releasing histamine. Okay. So basophils are going to be associated with histamine release, allergic reactions. Now, when you get into your agranulocytes, monocytes / macrophages, basically just general phagocytes. They're not really doing anything too crazy. Oftentimes they'll go in and they'll clean up after all the damage done by neutrophils. They can also get recruited by T helper cells so that they can go off and kill foreign invaders. Those are some of the things that macrophages do. And then lymphocytes. Lymphocytes are going to be the predominant cell types involved in your adaptive immune system. So you have your B cell and your T cell lymphocytes, right? And by the way, if you look at a lymphocyte underneath light microscopy, you cannot distinguish between a T cell and a B cell lymphocyte. They look absolutely identical. They're going to have different functions, but they look very much the same underneath light microscopy. So here are your cardinal signs of inflammation. If you want to do it in Latin, it's going to be calor, dolor, rubor, tumor, and functio laesae. Calor means heat, dolor means pain, rubor means redness, tumor, just like a tumor, means swelling, and functio laesae means loss of function. Functio laesae or loss of function is not always going to be present. You might see that sometimes. But the main ones that are always going to be present for inflammation are going to be these guys right here: redness, heat, swelling, and pain. Okay. Don't worry about all this other stuff. That's just FYI. So let's talk about antigens. Now, antigens are going to be antibody generators. So antigen literally stands for antibody generator. So when your body gets exposed to an antigen, then your humoral immune system is going to go ahead and begin producing antibodies that are specific to a particular antigen. Okay. An antigen can be made up of multiple different things. It could be components of a bacterial cell. It could be a hapten, which if you know anybody that has nickel allergies, like they wear like jewelry or something, all of a sudden they get an allergic reaction. Those are called haptens. Those are antigens from the nickel or whatever metal it is entering into the system, resulting in a mounted immunological response. Antigens can also be epitopes, which are little antigens that are found on the outside of a bacterial cell. I think of epitopes as being like the epithelial layer of a bacteria, even though that's not really like a great way to think about it. It's kind of like a false mnemonic, I guess, but it's a mnemonic nonetheless. It helps me remember what that is. So those are epitopes, but they're all antigens. They're all antibody generators. So these are going to be antibodies that are produced by your B cell lymphocytes when they turn into plasma cells. Those antibodies bind to specific antigens, whether it's an antigen free floating or it's an epitope on the outer layer of a bacteria, just kind of like what you're seeing over here. These are all examples of epitopes, right? Now, humoral response, that's what we're talking about when we're talking about antigens and antibodies. What the humoral response does is you have your B cells becoming activated, and then they proliferate and differentiate. And when they proliferate and differentiate, they're going to be targeting specific antigens. Okay. So when a B cell gets activated, it turns into a plasma cell. So let me just write that up here. B cell turns into a plasma cell. I'm just going to write PLAS. And then those plasma cells are what release immunoglobulins or antibodies. Same thing. It's a euphemism for the same thing, right? Immunoglobulins are antibodies. Antibodies are immunoglobulins. So that's what happens when you have B cell activation and proliferation and differentiation. Then your cell-mediated immune system is a little bit different. You have to have a cell that presents the antigen to the T cell. And once that antigen gets presented to the T cell could potentially get activated. Now, if a helper T cell gets activated, what the helper T cell does is two things. The helper T cell can go on to release cytokines to activate B cells to proliferate, differentiate, turn into plasma cells, and release antibodies. Or the helper T cell could also activate macrophages. I'm going to show you an image of what that looks like. I have a chart that gives you a good description of that. But they can activate macrophages, and that macrophage is going to go off like a hitman and do all the dirty work that was activated by the helper T cell. In other words, the T cell is kind of like a person hiring the hitman. The hitman's the actual macrophage. The macrophage goes off and does its dirty work, right? So it activates the macrophage to become more aggressive, to go ahead and phagocytose foreign invaders. And then you have cytotoxic T cells. And cytotoxic T cells, what they do is that they directly kill pathogenic cells. It could be cancer cells. It could be cells affected with viruses. What they basically do is they release tumor necrosis factor, or TNF. And tumor necrosis factor actually induces apoptosis, or controlled cell death, in affected cells. That could be a cell affected with a virus. It could be a cell affected with cancer, right? And that's what cytotoxic T cells do. They induce apoptosis. So it's like direct cell killing. So let's talk about immunoglobulins and how they, get activated and released upon initial exposure or secondary exposure. So primary response versus secondary response. Primary response, you are exposed for the very first time to an antigen, an infection. Maybe it's a virus, maybe it's a bacterial infection, etc. So your primary response takes about 10 days for it to initially activate. And when it does initially activate, the very first thing you're going to see that spikes is going to be your IgM, immunoglobulin M. Then the second immunoglobulins or antibodies that get released are going to be IgG. And IgG is what confers more long-term immunity. If you get your viral titers checked, like a lot of you are going to have to get before you guys start doing your clinicals at the hospital, they're going to check your viral titers for things like measles, mumps, rubella, right? Like for instance, when I was about to do my clinicals during med school, my rubella titers were actually low. So in other words, I had to go ahead and get the MMR vaccine all over again. Nothing really too crazy. Once I got my MMR vaccine for the second time, then my rubella titers came back up, right? And that's going to be a result of your IgG. So IgG is what confers long-term immunity. That's why when you get tetanus boosters and things like that, that's trying to ramp up your IgG production against that particular antigen. So that's going to be your first primary response, where you first get exposed to an antigen. Then those immunoglobulins kind of go into hibernation. You also have memory cells, right? So memory B cells, memory T cells, and they're kind of hanging out, right? They're going to be waiting to get exposed again to that same antigen. Once they get exposed again for the second time to that second antigen, that same antigen, but for the second time, that immunological response is going to be much more rapid. It's going to be 5 days. It's going to take about 5 days instead of 10. It's going to be twice the speed, right? And then your immunoglobulins are going to bounce right up so that you can fight off that antigen for the second time. This, if left unchecked, or if it goes awry, is what results in things like anaphylaxis, right? So if a person has like a peanut allergy, or they have like an allergy to bug bites, right? Like my dad, he's allergic to ant bites. You know, he got bit by an ant. He started to like go into anaphylaxis. It's because his B cells basically produced kind of became like out of control, right? And so they produce these immunoglobulins against that antigen. And once you get exposed for the second time, that whole entire reaction kind of gets out of hand. And so you get this kind of like overly aggressive secondary reaction. And so that can actually throw you into anaphylaxis. This can also happen to drugs. It can happen to basically anything. That's how you develop allergies. It's like this whole entire system becomes a little overreactive. So B cells, the biggest thing to know about B cells is that they mature in your bone marrow. So it's pretty easy. B cells, bone marrow. B cells are going to become activated and then they proliferate and turn into plasma cells. Those plasma cells are what release different types of antibodies, different types of immunoglobulins. And we're going to talk about those different types of immunoglobulins in a second here. T cells, another easy way to think about T cells is that they mature in the thymus. The thymus is going to be this gland right here. It sits anterior, superior to the heart. If you do a dissection on a cadaver, more often than not, your cadavers are going to be older people. Like for instance, the labs that I work with at GCU, and when I went to med school as well, most of the not patients, but the cadavers that we dissect, they're going to be people like in their 70s, 80s, sometimes even their 90s. By the time you start getting to that age, your thymus gland actually starts degrading. A lot of older people don't really have much of a thymus gland left, which is one of the reasons why you have older people being more susceptible to things like influenza or other viral infections, right? The older you get, the less of a robust immunological reaction you're able to mount against a foreign invader, right? Like a viral infection. Young people too, right? When it comes to influenza, it's very young and very old. Those are the ones that are more susceptible. Young people, because they don't really have much of an immune reaction, because they haven't really developed all the antibodies against foreign invaders as a cell-mediated immune reaction. But so anyways, long story short, T cells, think thymus. Two major categories of T cells are cytotoxic versus helper T cells. You also do have regulatory T cells. What those regulatory T cells do is that they actually help to reduce the total number of T cells that are in your system. Reason being is, think about autoimmune disorders. Autoimmune disorders are usually a result of your immune system being kind of bored. Your immune system likes to be kept busy. Your immune system likes to have something to fight off. Here in the developed, West, in developed countries, you see a greater amount of autoimmune diseases. The reason being is because we have such great sanitation. Our infrastructures are really good. Water is generally clean, that your immune system doesn't really have any foreign invaders to attack, right? So what happens is your immune system starts getting bored and starts attacking itself. That's why you get, things like celiac disease. You have like peanut allergies. It's more of a phenomenon here in developed nations. You get things like, not osteoarthritis, but what's the other one? Oh my gosh. Rheumatoid arthritis, things like that. Those are all going to be something you see more in developed nations. In underdeveloped nations where the water is maybe a little bit like dirtier, there's more parasites, the immune system tends to be a little bit more active in fighting off those infections. So you see less autoimmune diseases. But anyways, autoimmune diseases are going to be reduced by these regulatory T cells. So they basically kind of prune back the number of T cells that are available in your immune system. So this image right here is a really good summary of your humoral versus cell-mediated immune system. This over here on the left side is going to be humoral. Oh my God, my handwriting is terrible. That's all from my mouse. Okay, so I apologize. That's humoral, and then this over here is cell-mediated. I'm just going to like write cell med. So that's cell mediated. So humoral, you have your B cells. They get activated, they proliferate, they differentiate, they turn into plasma cells, and those plasma cells are what produce antibodies. Now, on the other hand, your cell-mediated immune system, remember we talked about dendritic cells. These dendritic cells have those little finger-like projections. They go off into the environment. They pluck out little potentially pathogenic antigens. What they do is they present those antigens to either helper T cells or cytotoxic T cells. Helper T cells, once they get activated over here, then they're going to activate macrophages. And those macrophages thereby become more aggressive. And those macrophages become like little hitmen, right? They're going to go off and they're going to do all the dirty work, all hired by those helper T cells. Your cytotoxic T cells, on the other hand, are going to release tumor necrosis factor, TNF, and tumor necrosis factor is what induces apoptosis or controlled cell death in those infected cells. Oh yeah, and by the way, those helper T cells, not only are they activating macrophages over here, they're also going to be releasing cytokines that can help to activate those B cells to become plasma cells and release immunoglobulins. So this is a really good chart, gives you a really nice summary of the humoral versus cell-mediated immune system. So, any questions so far before we start talking about immunoglobulins?
I have one question. It's just back on that first chart with the graph when you're first exposed to the antigen.
Mm-hmm.
You know how when you don't get the same virus twice, like the same strand twice, if that makes sense. You know how like if I got the flu virus once, the likelihood of getting that same strand wouldn't be as likely.
Right. No, that's totally true.
So if I got this, like when my body, obviously if I got exposed the second time, but to a different strand of the flu, even though it is the flu, would my immune system response be as fast as opposed to the first time? Even though it's a completely different virus, but I've been exposed to the flu before.
So different, yeah, there's different serotypes. So when we start getting into the viral component of this class, we're going to talk about things like hemagglutinin antigen and neuromanidase antigen. So HA versus NA, those are going to be part of the spikes that project off of the virus. And those spikes are going to be targeting specific receptors on your epithelial layer in your respiratory system. Those spikes are going to change depending on the serotype of the virus. And those serotypes are going to be determined by either point mutations that are going to, determine like things like antigenic drift versus antigenic shift, which we're going to talk about later, which is where you have two different serotypes combining into one virus that creates a novel virus. We saw that with the swine flu epidemic, as well as the avian flu epidemic, as well as like Spanish flu way back in the day in 1917. Those are all like novel viruses that create like pandemic type situations. Those are all going to be different serotypes of similar viruses, right? They're all like influenza, but they're going to be different serotypes. And yes, if you are exposed to one specific serotype, now you're going to have that immunity against that serotype. But what happens with seasonality with flu, for instance, and even other types of viruses like rhinovirus, coronavirus, all those viruses that rapidly mutate every year, you're going to have different serotypes every year. So you're going to be exposed to basically like a novel virus. And once you get exposed again, but to a novel serotype, then you're going to basically have that primary response. It's going to be just that.
Oh,
right?
so go back, even though it's not the same. I mean, would it be a second? Okay.
It's if you're exposed to a different serotype, it's going to be basically like you're getting exposed
to a new virus. It's just a new virus. Okay.
Exactly. So like if you had vaccinations against the three major serotypes of influenza, those are the ones that you're going to confer immunity against, right? But if you get exposed to a different serotype for whatever reason, then you're going to basically have like a primary response. It's as if you've never been exposed to it before.
Really interesting, because you'd have different symptoms. You would maybe not feel as bad as you had the first, like influenza A versus B, even though you'd feel like they're different. So
influenza A generally is more severe than influenza B. Influenza B is not as serious. Influenza A is the more aggressive one that causes more like pathogenicity. But yeah, it's like if you don't if you've never been exposed to a certain serotype, it's as if you've never been exposed to it before. So you're just going to mount a primary response. Does that make sense?
Yeah, for sure.
Awesome. Rock and roll. All right. Good question. That's a really good question. I hope I answered that adequately.
Yeah, I always wondered that too, because you'd always think that maybe you would restart your response or you would just continue on because you've had the virus, but
Right.
it's really different. So
there's also
immunity.
over time, your immunoglobulin levels against those particular antigens, they do tend to wane over time. That's why they recommend, like tetanus, for instance, they recommend, oh, get another booster like every 10 years, right? So you want to get that booster shot just so you get re-exposed to that antigen, right? Like I said, with the MMR, I had the MMR when I was a kid, but my titers for rubella dropped. And so I had to get the MMR again. That's because over a period of time, eventually your immunoglobulins start dipping off. And so you're going to have to get re-exposed to those antigens. So speaking of immunoglobulins, there's 5 major ones that you should be familiar with. There's IgG, IgM, IgA, IgD, IgE. So to summarize these different immunoglobulins, the way I like to remember IgG is I think of it as Ig girl. It's going to be very important in pregnant women. IgGs are going to cross the placenta to confer immunity to the child, right? The developing fetus is going to be taking on IgGs from mom. It's also going to be conferred through breastfeeding, okay? IgG. So that's going to be breastfeeding as well as crossing the placenta. So think IgG is Ig girl. And on top of that, it also confers long-term immunity. Okay. IgM. IgM is interesting because it forms these pentamers. So you got this like large pentameric shape. What that does, you're going to find this a lot in your bloodstream. When the IgM attaches to something, like maybe say it's a bacteria, it's going to prevent the bacteria from entering into the interstitial space. It's going to keep it trapped within the circulatory system in the bloodstream so that your leukocytes, your white blood cells, can come in and basically take care of that foreign invader. So that's one good way of thinking of IgM. IgA is going to be predominantly associated with mucosal membranes. So mucosal membranes in your GI tract, genitourinary tract. It's also going to be associated with breast milk. So you can actually get IgA transferred over to the child as they're breastfeeding. The other interesting thing about IgA is that it forms a dimer. So I think of IgA as like being connected by the head of the A. So it's going to be 2 A's combined together. And then IgD, I call it who gives a damn, because nobody really knows what IgD does. And it's only really known to help other immunoglobulins develop. And then IgE is going to be associated with histamine response. So in other words, mounting an allergic reaction. It's going to be released by both mast cells as well as basophils. Okay, so it's going to be allergic reactions. So here is the overall summary of those different immunoglobulins. Okay, so it's good to know, especially IgG is very important. IgM is pretty important as well, because IgG and IgM are both going to be associated with that primary and secondary response. IgA is going to be good for immunoglobulins found in your GI tract, mucosal membranes, and then IgE is going to be associated with allergic reactions. One couple things to keep in mind about immunoglobulins. There's a couple of regions that you should be familiar with. There's the FC region, and there's going to be FAB region. C stands for crystallized, but I like to think of it as constant. The FC region is going to be constant among every single class of immunoglobulins. So in other words, for IgGs, they're all going to have the same FC region. It's all going to be constant. The only thing that's going to change amongst different IgGs is going to be the FAB region. FAB is the antigen binding region. So the antigens can actually bind to both of these areas. So it's going to be two different binding spots at the very tail ends of the Y. And the tail ends of the Y are made up of both a heavy chain, which is going to be the innermost part of the Y, and then the outermost part of the Y on the lateral side is the light chain. And then the FAB, the antigen binding region is going to be the merging of the light chain with the heavy chain. And you have two of those on both sides of the Y. So let's just kind of recap with all these. IgM, it's going to be associated with your primary response along with IgG as well. It's going to form a pentamer. It's going to be found mostly in your bloodstream. So prevents organisms leaving the bloodstream into tissues, right? So it keeps them trapped into the bloodstream. IgG, it's going to be one of the most common ones found in your system. It's going to be 80 to 85% of your serum immunoglobulins. It's going to be associated with pregnant mothers, right? It crosses the placenta. So those are going to be some of the major things associated with IgG. It does all sorts of different things from neutralization to aggregation, opsonization. We're going to talk about these different immunoglobulin reactions later on in the semester, so don't worry about that for now. Just know that IgG is associated with fetuses and newborns because it not only crosses the placenta, but it's also going to be associated with the colostrum, which is the first bit of milk that's consumed by the neonate. IgA, remember, it forms those dimers, right? So it combines together, it connects at the head, and it's going to be found in your mucosal membranes, okay? Mucosal membranes, especially in those mucosal associated lymphoid tissues, right? We talked about MALTs. That's where you find lots of dendritic cells, right? You're also going to find a lot of IgAs in those regions too. IgDs, like I said, really, who gives a damn? Not really too many going on, not really clearly defined in terms of what they actually do. They just kind of help other immunoglobulins mature. And then IgE associated with basophils and mast cells, histamine response, allergic reactions, okay? So that's going to be the key components of IgEs. Any question on immunoglobulins? Okay, rock and roll. So let's talk about transmission. We're gonna talk about transmission and chains of infection quite a bit throughout the semester. But let's just kind of go over like the major components of transmission. You can have direct contact, which would be like, for instance, shaking someone's hand, or even droplet transmission. If somebody is within 6 feet from you, you cough on them or you sneeze on them, and all of a sudden you inhale their droplets, that's going to be associated with direct contact. That's direct transmission. Indirect transmission would be fomites, vectors, and even other airborne mechanisms. So fomites are anything that is non-living, that is able to harbor a pathogen. You need to know what that term is. A fomite is anything that does not live that can potentially harbor a pathogenic organism. That could be a door handle. When I was doing my surgery and pediatrics rotation in the United Kingdom, we had, in the UK, they have a nothing below the elbows policy. That means no wedding rings, no watch. You don't wear a white coat. If you have a long sleeve shirt, you roll it up above your elbows. The reason why is they want to reduce fomite transmission of organisms. And because of that, in the United Kingdom, you actually have a very low rate of MRSA. You guys are familiar with MRSA, right? So MRSA is a very aggressive form of Staph aureus. In the UK, they dropped those rates of MRSA in the hospital tremendously compared to the United States because of their nothing below the elbow policy. And that's because you get a reduction in fomite transmission. Vectors are going to be things like arthropods, right? So think about insects like mosquitoes, for instance, even animals that bite you. Maybe think about like a rabid raccoon. That would be considered a vector. And then airborne transmission, that's just, it's floating around in the air. That would be beyond 6 feet, right? So even if somebody coughs, it's beyond 6 feet, that's going to be considered airborne type transmission. So here is an image of that chain of transmission. You have things like a reservoir, you have the portal of exit, then you have what the actual transmission is, whether it's like, direct transmission, or maybe it's like oral fecal, something like that. Then you have the portal of entry where it actually enters into your body. And then you have the susceptible host at the very end. In the surgical setting, if you had contaminated surgical utensils or tools, maybe like a scalpel blade or like, a retractor or something like that. If you had something that was contaminated, that contaminated thing would be the reservoir. And then the actual portal of exit would be from the reservoir into the person's body, right? And so the portal of entry would be into that, the incision, right? And then the susceptible host would be the person that gets the actual infection at the end. Here's another image of what those chains of infection might look like if you're involving things like an arthropod for like malaria, with like a mosquito bite, for instance. So let's kind of briefly go over some of these different chains, reservoirs. So reservoirs could be animals, humans, environment. A lot of bacteria are going to be found in the environment, especially in soil and water, right? A lot of our spore-forming bacteria, like Clostridium tetani, that causes tetanus, that's going to be found in soil. Anthrax can be also found in soil. Could also be found on things like sheep, right? They call anthrax, sometimes they're referred to as wool sorters disorder or disease. Water, E. coli, could be something like Cryptosporidium parvum, right? So if you get cryptodiarrhea from drinking contaminated water, the water would actually be the reservoir. And then in terms of non-human reservoirs, those would be referred to as zoonotic type diseases. That's why I include this image here of a raccoon. In the United States, raccoons are going to be one of the major carriers of rabies. Also, of course, like bats, things like that. But those are going to be non-human animal reservoirs. So very common in terms of transmitting different types of infectious diseases. And then in terms of different chains of infection, so routes of transmission, intestinal tract, that's going to be your fecal oral route of transmission. Respiratory tract is going to be, different types of respiratory infections. Tuberculosis is a good example of that. Skin, so that'd be direct contact with somebody. If you shake someone's hand, maybe one of the common places you find, for instance, Staphylococcus aureus is going to be in your nose. Somebody picks their nose, you shake their hand. If the person has Staph aureus, now you just got Staph aureus on your hand. That could potentially become an infectious agent. And then for genital urinary transmission, oftentimes we're talking about intimate contact. So a lot of your STIs are going to be associated with genital urinary routes of transmission. Any questions so far on routes of transmission? So let's talk about the two major routes of transmission in terms of vertical versus horizontal. So vertical is going to be person to person, right? So you shake someone's hand or you cough in their face, all of a sudden now you have vertical transmission of a pathogen. Horizontal transmission is going to be mother to child. So we're going to talk about HIV/AIDS in a couple of weeks here. If mom is infected with HIV/AIDS and she does not take prophylaxis, there's going to be certain drugs you can take that can help reduce, like zidovudine, things like that, that can help reduce the route of transmission to the child. If mom doesn't take those prophylaxis during childbirth, the child could potentially get infected with the virus. Other illnesses that we're going to talk about are things like GBS, which is group B streptococcus, can also be vertically transmitted to child. Gonorrhea as well as chlamydia can also be vertically transmitted to child from mother to child. Also, HIV/AIDS during breastfeeding can be transmitted through breast milk. So those are all going to be considered horizontal routes of transmission. Sorry, vertical routes of transmission from mom to child. We already talked about direct contact. We talked about droplet transmission. So let's move forward here. And then we talked about air. So with air, think about anything that's above 6 feet away from another person. And then fomites, let's just recap on fomites. Fomites are going to be anything that's non-living. Even though chicken is, used to be a living organism, right? Because it's dead and it's now being like prepped into food, that can also be considered a fomite. It's non-living. It's a non-living thing that can potentially transmit disease. One great bacteria example from chicken or poultry in general would be salmonella, right? So salmonella would be considered transmitted through a non-living fomite through chicken. Cryptosporidium, I included this little article here because fomites can also be considered water, right? Water can be considered a fomite. Back in 2015, have you guys ever been to Wet and Wild? It's off of the I-17 North Phoenix. Wet and Wild is a water park. And back in 2015, they had an outbreak of Cryptosporidium parvum. They call it cryptodiarrhea. My best friend, him and his family, I went to Wet and Wild, and then my best friend and his family actually went the day after I went. When I went, no Cryptosporidium. The day after, there was a Cryptosporidium outbreak. So my best friend and his entire family got very severe diarrhea from going to Wet and Wild water park. And that was spread through the water. Crypto can live in chlorinated water. So now they actually installed this super expensive UV light filtration system that can actually kill off crypto. So you don't really run the risk of getting it nowadays. So kind of an interesting story that kind of comes close to home. In terms of vectors, so we talked a little bit about like raccoons, for instance. Those would be considered like a zoonotic type vector. Very common ones are going to be arthropods, so mosquitoes. That's going to be, for like malaria, yellow fever, dengue, things like that. Flies can be considered vectors. Fleas can be considered vectors. So those are all going to be vectors that can potentially transmit infectious diseases. And we'll talk about those in more detail throughout the semester, but this is just, like I said, an overview of all those different elements. So it is now 7:10. Do we have any questions, or do you guys want to jump straight into quizzes so you can clarify anything that you might need to know in greater detail?
I'm good with the quizzes.
Yeah, awesome.
Yeah.
Sweet.
Yes.
Let's do it. So I'm going to stop sharing. Actually, do you guys see my screen right now? Do you guys see the quizzes right now? Okay, here, let me stop sharing, and then let me do a new share. There we go. All right, here's the new share. All right, so do you guys see the screen now for you guys to log in to quizzes? Yeah? All right, cool. So let's do it. There are 20 of us. So once all of you guys get logged in, we'll go ahead and begin. If any of you have a tough time logging in, like I said last night, go ahead and put your name in the text box on Zoom so that I can save your name so I can put you into the attendance sheet. How's everyone's night going so far? Good? Awesome, awesome. So usually I like to go like 1 hour into lectures on our lab nights. We've kind of already went over that 1 hour mark. So we'll do these quizzes for the next 10 or so minutes. If we don't get through all of them, then we'll start next week's lecture on Tuesday night, leaving off where, starting where we left off, okay? So we'll go until 7:25, your guys' time. All right, is everybody logged in? Shall I begin? All right, I'm going to go ahead and start. So Rock and roll. Looks like most of you guys got this one correct, which is great. So skin, lysozyme, phagocytic cells, those are all part of your innate immune system. In other words, they're non-specific. They do not need prior exposure to a particular antigen, right? So if it's the adaptive immune system, adapting means that they need to have prior exposure to an antigen for them to actually become activated. So let's go to the next one. Excellent. So you guys got this one correct too. They're pretty straightforward questions. So innate immune system, of course, you're born with that, right? So you do not need any prior exposure. You're just born with it. Skin, lysozymes, even your inflammatory type process, that's all going to be part of your innate immune system. Neutrophils and macrophages. All right, so this is very much across the board. Okay, cool. So let's go through these one by one. So both neutrophils and macrophages, what are they? What's like the common theme amongst those types of cells? So they produce immunoglobulins. No, they don't. Lymphocytes are going to be what produce immunoglobulins. Do you guys remember which lymphocyte specifically produces immunoglobulins? Is it B
Say
cells?
that again.
Do you guys remember which lymphocyte produces the immunoglobulins? Is it the B cell or the T cell lymphocyte?
I think it's a T cell.
No. So T cells,
No?
T cells are going to be major categories: helper T cells and then cytotoxic T cells. What the helper T cell does is that the helper T cell helps to activate macrophages to go off and phagocytose organisms, or the helper T cell can now activate B cells. And once they activate the B cell, then the B cell is going to differentiate, proliferate, and turn into a plasma cell. And then that plasma cell is going to subsequently produce immunoglobulins that target a specific antigen. The other T cell is going to be your cytotoxic T cell, and those directly induce apoptosis in affected cells. So your B cell lymphocytes are going to be associated with the production of immunoglobulins, i.e. not neutrophils nor macrophages. Mounting an adaptive immune response. Neutrophils and macrophages are not necessarily associated with adaptive immune system per se. Macrophages could be in one regard, insofar as they become activated by helper T cells, right? But generally speaking, macrophages, they're able to just detect foreign invaders and they're able to gobble them up. Or they're able to clean up after all the destruction that neutrophils cause. Yes, they both do phagocytosis. Neutrophils and macrophages can do phagocytosis. And the very last one here, oxidative burst, that's associated with neutrophils specifically. Any questions on that? Or do you guys got it? Okay, cool. Let's go on to the next one. Awesome. Looks like most of you guys got this one correct, which is fantastic. So cytotoxic T cells, what do? Do they present antigens to B cells? No, that's going to be your helper T cells. Helper T cells are going to release cytokines that are able to actually activate B cells, helper T cells. They help to activate macrophages and they help to activate B cells. Cytotoxic T cells are going to directly induce apoptosis in affected cells. So just make sure you know what the helper T cell versus the cytotoxic T cell and what their roles are. Awesome. Looks like the majority of you guys got this one correct as well, which is great. So yeah, B cells, bone marrow, T cells, bone marrow and differentiate plasma. Yep, exactly. So once a B cell matures, it's going to differentiate, proliferate, plasma cell, and it's going to secrete specific immunoglobulins. That's perfect. And then T cells, think thymus. That's where they mature. And it looks like we might be able to wrap things up in time so we can we won't have to do these questions next time we meet. All right, so IgG. So let's go through these one by one. Most of you guys got it correct, but let's just go over. So genitourinary, you're thinking mucosal membrane. You're thinking like IgAs. GI tract, very similar. You're thinking mucosal membranes, IgA. Bloodstream, you're thinking IgM, right? They form those pentameres and trap bacteria or whatever into the bloodstream so they can get phagocytosed. Crossing the placenta and providing immunity to developing fetus, that's going to be IgG because they're thinking IG girl, right? Last one. All right, awesome. Most of you guys got this one correct. Pretty straightforward. Think fomites, think a non-living object, right? Could be either like a door handle, or it could be something that used to be alive, like, you know, a piece of chicken or something. And that could also be considered a fomite because it's non-living. And that's what transfers potentially pathogenic organisms to the host. So great job on that, guys. As we wrap up, do you guys have any questions? Pretty straightforward.
I do.
Yeah, you got a question?
Yeah, but not in relation to this. I can wait until we're done. Right.
Oh,
Right.
okay.
We're getting ready to sign off. It's cool.
Sounds good. Well, if anyone else doesn't have a question, then feel free to sign off and I'll linger around afterwards to answer your question in private. So awesome, guys. Have a great night. Enjoy the rest of your week. And I will see you next Tuesday in person.
Thank you. Have a good night.
Yeah, my pleasure. Have a great night, guys.
Good night.
Yeah, it was nice to see y'all.